All right. Can we start, or do you want me to wait? Okay, guys. Okay. Hi, guys. My name is Dr. Close. I'm one of the hospitals here at Metro, and today we're going to talk about transitions of care. So our learning objectives for today are we're going to be able to describe the roles of the interdisciplinary team, identify and implement the 5 W's of a discharge or dispo plan. We're going to perform a medication reconciliation and learn how to write an effective discharge summary. So this figure here just demonstrates all the transitions a patient may make in their care. So what exactly is a transition of care? So it's any movement a patient makes between healthcare practitioners, settings such as inpatient, outpatient, SNF, and home. And this is as their condition or needs change. So transition of cares don't always go smoothly, which is why this talk is important. Okay, so ineffective transition of care can lead to adverse events and higher hospital readmission rates and costs. One study estimated that 80% of serious medical errors involve miscommunications between handoffs, and it can happen between any of these motions a patient may make, but most of them happen when the patient goes from the hospital and then either home or to SNF, okay? So ineffective transition of care can also lead to increased mortality and morbidity, delays in receiving appropriate treatments or community support. So if a patient has a procedure done in the hospital, like a biopsy, and no one follows up on those results, and they do have cancer, they can miss out on treatment, okay? It can lead to additional PCP visits or emergency department visits, readmissions, additional duplicate testing, tests that are lost to follow up. It can lead to emotional and physical pain for the patients and caregivers, and it also leads to patient dissatisfaction. So transition of care are accompanied by changes in health status and maybe functional status as well, and it affects how the patient's able to take care of themselves on the outside world. So has anyone discharged a patient since they've started residency since July 1? How many of you have discharged someone? Raise your hand. Okay, and keep your hands up if one of those patients you discharged has multiple admissions and readmissions. Okay, so you guys, what could have been done to prevent these readmissions? Just throw some things out. What could have been done to prevent those readmissions? Okay, anything else that you can think of? Go ahead. Okay. Okay, all right. So in general, what are some causes of ineffective transition of care? So you talked about PCP follow-up, maybe things that should be treated as an inpatient, but what other general things can lead to ineffective transition of care? Take a few moments, you're kind of sitting in groups, talk about it, and then we'll reconvene. Okay, I'll give you 2 minutes. All right, guys. So tell me what you came up with. We'll start with Ben, because I only know your name.
Making sure that there's like the med recs done and clear instructions on taking this medication.
Yeah. Very good. Okay. Some group over here. What are some things you came up with that cause ineffective transition of care?
Not having all the follow-up scheduled before you start.
Yeah, very good. Okay. And then one more group. Yeah. Yeah, very good. So it sounds like a lot of what you guys came up with was communication. Okay, so breakdowns in communication are an issue with ineffective transition of care. So communicating, one, with the patient, like you said, any changes made to medications or what they need to do, they need to know this information. Just because they get a discharge packet, it's not always clear and it's not easy to follow. Someone needs to go over it with them, and that's your guys' job to do, okay? And then communicating with the nurses, communicating with the outpatient, the PCPs, so having a effective and timely discharge summary, okay? And then patient education, if they don't understand these things, they're not set up to, do well as an outpatient, okay? They're set up to fail. And then accountability breakdowns, so if someone's needs to follow up things as an outpatient, someone needs to be accountable for that, and not everyone has a primary care doctor, so even though they're gone from the hospital, we're still accountable for these things, okay? And for answering questions that the patient may have. Okay. So I know this is very wordy, but these are just two examples of ineffective transitions of care. So the first one is a 68-year-old male. He's readmitted for heart failure only 1 week after being discharged following the treatment of the same condition. He brought all his pill bottles in a bag. All the bottles were full. None were opened. When questioned why he didn't take medications, he began to cry and explained he had never learned to read and couldn't read the instructions on the bottles. The second one is a 78-year-old lady, came into her PCP. She was given blood pressure medications for her hypertension. Her doctor instructed her to start taking the new medication the same day and stop taking the old medication. So they also had home care come visit her. When they came and saw her, her blood pressure was still elevated, and when asked why she wasn't taking the new medications, she said she couldn't afford them. Okay, so for this, we kind of assume that the patient can read or understands the instructions or can afford those medications, and that can be harmful to the patient. You need to ask these things, okay, because patients aren't always going to be forthcoming with that. It can be embarrassing for them. Okay, so, we kind of already discussed what things you could do to improve transitions of care. We talked about the quality and timeliness of discharge summaries, effective medication reconciliations, patient teaching, and close follow-ups. And then, also getting their families involved is a good idea. So they have that support system at home to help with their medications and other medical problems. And then what might be some patient factors that, affect the transition of care or their ability to succeed as an outpatient? Do you want to take a couple minutes and talk about that? What things are patient-centered? Give you 2 minutes again. All right, guys, so what did you come up with? We'll start with this side of the room now. What things about the patient may make ineffective transitions of care? Yeah. Sure, very good. Okay. Middle side, top row, someone tell me what you guys came up with. Sure. Yeah, that's okay. That's okay. Yeah, yeah, that's very important. Yeah, yeah, exactly. You really hit on a lot of them. So can they understand the instructions? Okay. Do they have a support system at home to help them? Do they have a well enough functional status? Like, can they get to their appointments without help? Can they do their ADLs on their own, get their medications and do that kind of thing? Do their patients' suitability of their home, like, do they just have a stroke and they have some weakness and difficulty walking and they live on the third floor of an apartment without an elevator? So how are they going to get the 3 flights of stairs? Okay. And then you talked about support system, their health literacy, and then transportation and ability to get medications. The great thing about Metro, though, is our social workers and case managers have a lot of resources to help get patients to their appointments. We've got the Metro van. They also can work with their insurance companies. And then medications at Metro are very inexpensive. We have the 340B plan, which, the medicines are very inexpensive cash price. Okay, so good discharge planning starts on as soon as they come to the hospital. Okay, so not only are you working on whatever medical problem brought them here, you have to maybe identify things that will keep them out of the hospital. And I don't know how many of you have been on the general medical floors yet, but the social workers and case managers interview all the patients and talk about what their needs may be homegoing and if they're at risk for being readmitted. And also in EPIC on the top bar, there's a readmission risk score, which kind of helps you determine if they're at high risk for coming back to the hospital or not. Okay, and these are patients you really need to pay attention to so they can be successful as an outpatient. So the interdisciplinary team, so you've got the social worker and the case manager. So the social worker arranges discharge to SNF. They work with the insurance company for pre-certs. They address any homegoing concerns, and they're also a good resource for substance abuse resources. And they work with Thrive, which is a group that helps people with substance abuse issues here in the hospital. Case managers, they arrange home care services like PT, OT, skilled nursing, home health aides. They also arrange homegoing IV antibiotics, as well as community hemodialysis chairs. There's the physical and occupational therapists. They do the formal assessment of what a patient may need homegoing in terms of are they safe to go home from a functional standpoint? And that being said, not every patient needs physical therapy and occupational therapy. And then there's a secretary. They make the appointments for you. And then there's a nurse who does patient education. So that's the team. And every day you do, the senior and the attending do interdisciplinary rounds with this team to kind of go through the patients and what the plan is. Okay. So we're going to start with the case. This is Mr. S. He's 56. He has a past medical history of hypertension, type 2 diabetes with an A1C of 16, hyperlipidemia, currently smokes. He came in with shortness of breath. He was admitted for acute decompensated heart failure exacerbation. During his stay, he had an echo, which showed an EF of 30%. And he had an elevated creatinine when he came in, but you're unsure of his baseline. So during his course, he was complicated by an AKI from presumed overdiuresis. His creatinine downtrends, but it's not quite back to his baseline, and the shortness of breath is resolved. He had a CTPE during his stay, which showed small bilateral pleural effusions and a small 2-centimeter pulmonary nodule, which it was recommended he have a follow-up CT in 3 to 6 months. Your attending tells you that Mr. S is medically ready for discharge today and then just leaves. So how would you approach his medical or his discharge now that he's medically ready. So, the way that I like to think about it is the 5 W's of follow-up. And this kind of just keeps you organized so that you don't miss things. And there's not one right way of thinking about it, but this is pretty easy. So the first question is, where does he need to be discharged to? Is he going home, a SNF, LTAC, or PM&R? And who does he need to follow up with and when? And then what does he need at the time of discharge? And by that I mean what, like labs, imaging, that kind of thing. And then does he need any supplies? And why? Does he understand all of this? And that's really important for this. So medication reconciliation. Yes, you do need to do this. It's not the nurse's job, it's not the emergency department's job, and it should be done every single patient, okay, and it should be part of their admission, all right? I'm not gonna go through in EPIC how to do it. You learn that as you go, but it should be done every time. So more than 40% of medication errors are believed to result from inadequate reconciliation during handoffs. So from admissions, transfers, and discharges. And then 20% of those errors are believed to result in harm to the patient. And again, it should be done at every transition. Even as an outpatient, when you're seeing these patients in your clinic, you should do a medication reconciliation. So this figure, it just really hits home on what we just talked about, that there are errors with medication reconciliations in every step of the way. So this is from the HWO. In the hospital admissions, this is a really big range, but 3 to 97% of patients have a erroneous MedRec, okay? And then between transfers, 62% of patients did, and at discharge, 25 to 80% of patients, and then anywhere from 14 to 98% of adults in the community had medication discrepancies on their med list. So for medication reconciliation, accuracy is key. So you need to verify. So you collect an accurate medication list. What's in the EMR is not always right, okay? They might be being seen at different hospitals. They might not have followed up for years. So, and a lot of the time the patients will say, I don't know, I'm on. So, they might not be able to name them, but if you go through the list and ask, are you taking lisinopril, they might be able to tell you that. If not, you need to go to other sources. So call family, friends, pharmacies, and SNFs to get a list. That's really important. You need to do your due diligence on this. Otherwise, you don't have an accurate list and a lot of errors can happen thereafter. And then clarify the medication doses and make sure they're appropriate. And ask them if they're actually taking these medications, okay? And then after you've done all that, you need to document this in that, in EPIC, and the ED or direct admission part. So if you did all that work, what's the point if you don't document it? And more importantly, so if you're not necessarily going to be discharging that patient, like you go off service or you're off for the day, it's important for the person picking up that patient to know that this MedRec was done and do the appropriate medications at discharge. So the next step is intern planning. So basically you should have a medication reconciliation plan for rounds. And having this plan allows you to discuss the plan with your attending and the senior during rounds. So you want to know what medications you're going to start, stop, or change. So for instance, say a patient came in for community-acquired pneumonia, they're on ceftriaxone and azithro. What are you going to send them out on? Okay, you're not going to send them on ceftriaxone because that's IV. So you need to have a plan, okay? The other thing is ask the patient where they want their medication sent. Don't assume whatever pharmacy is listed in the chart is where they want it sent, okay? So they could want it from an outside pharmacy, paper scripts, or meds to beds. And then if you're discharging on the weekend, primarily Sundays, make sure that pharmacy is open. Our pharmacy is not open on Sundays. So, you really have to have some forethought about if you think they're going to be discharged over the weekend to kind of plan this ahead of time. And then if the patient was transferred from another unit and they maybe did some discharge reconciliation in MedRec and they sent, I don't know, say Eliquis to the pharmacy and you're no longer sending that patient on Eliquis, but you're sending them on warfarin, you need to call the pharmacy and say, hey, don't fill that. It was a change of plan, okay? So we're going to talk about discharge summaries now. So in your groups, again, take a couple minutes to talk about what you would want or what you think is a good discharge summary if you were the receiving doctor, either the PCP or the patient coming to you in a sniff. So just take a couple minutes. All right, guys. So what do you want to know in a discharge summary? What do you think makes it useful? All right. What makes the discharge summary useful? What would you want to know?
Make sure it's concise, so they know what happened on the month. They don't want to read, get a 48 edition of everything that happens every day. It's what was the problem? What are the things going on? What was our plan? And what are we wanting them to see more?
Yeah.
What are the goals?
Exactly.
I'm not trying to guess.
Yeah, very good. Okay. What else would you want in a discharge summary? Yeah. 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 Very good. Okay. Anything else this group wants in a discharge summary? Right, exactly. The receiving doctor shouldn't have to guess or like rifle through, 40 days of admission to figure out what happened or what needs to be followed on. Okay. All right. So discharge summary expectations. So if a patient's going to sniff or PM&R, the discharge summary needs to be done prior to their discharge, and you need to use the sniff discharge template. And then all of their discharge summary should be completed within 24 hours of the discharge. You can use a discharge summary in place of a progress note, but you need to include a physical exam for that day. But if it was someone who's like, again, here for 40 days in a really complicated course, not do that, keep it organized and concise. Okay. So the discharge summary requirements, you guys hit on a lot of this. So the first thing is you want to know why they were hospitalized. It should only be 1 to 3 words. So Mr. S, heart failure exacerbation, or acute decompensated HFrEF. So significant findings. You don't need every single lab that the patient got, okay? Only things that you like, so he had an AKI, so you might want to trend his creatinines, or he had a CT that needs a repeat that we need to be followed up on. So maybe put his CAT scan in there. And then any important micro or pathology. Okay, again, not every lab that they had needs to be put in there. Okay. And then any procedures performed, any other treatments or services provided, and then a brief hospital course, 1 to 2 paragraphs, which should be concise and easy to follow. What their condition is at discharge, okay, and then their medications at discharge, and that's a DOT phrase, that I've listed for you, and then a list of what needs to be followed up on. And then even more importantly is your name and your pager. You are still responsible for any questions that the patient may have or that the receiving provider may have at the time of discharge. Okay. So back to Mr. S. Go back to the screen. So he's ready for discharge. So the first question in his discharge planning, where is he going to go? Okay. So he had been here, I don't know, 5 days. He was in bed the whole time. So the nurse asks, does he need physical therapy? So would you get physical therapy on him necessarily? Does anyone have any thoughts on that? Ben, do you have any thoughts on that?
Not necessarily.
Okay, so go ahead.
If he's 6-year-old now, 5 days, I guess it depends on if he's going to stay or.
Yeah. So you asked the nurse to walk him. He does well. So you decide not to get physical therapy involved. And he's safe for a home discharge. Okay. So you have this on your list, what medications he's taking at home. So at home, he's on hydrochlorothiazide, Lipitor, metformin, albuterol as needed, and lidoderm patches. While he's admitted, you're giving him low pressure, Lipitor, Lantus, and Lasix. And then because you are all great interns, you actually did a medication reconciliation on admission. He said he was taking everything besides the lidoderm patches at home. So I want you guys to take 5 minutes to talk about his medication reconciliation at the time of discharge. So what you're starting, what you're stopping, what you're changing, and what you're continuing on his med list based on what he's taking at home and what we're giving him in the hospital. So take a couple minutes to do that now with your groups. All right, are you guys ready? All right, so what medications do you want to start for this patient? Start in the middle. Yeah. What else? Okay, do you want to start anything else? Okay. Okay. All right, does anyone else want to start anything else or have anything different? You just want me to tell you. All right, so in terms of the beta blocker, he's got HFrEF, so you wouldn't necessarily do low pressor. You would either do Toprol or Coreg. Okay, so since he was on low pressor here, 25 BID, you could start Toprol 50 homegoing. Okay, and then the Lasix, yeah, you'd want to send him home on that, right? He came in for acute decompensated heart failure, requiring diuresis. His A1C was 16, so we were giving him Lantus here. We would probably continue that homegoing too, right? Metformin's not just going to cut it for him. And then he's a diabetic with risk factors for ACS or coronary artery disease, so an aspirin also. What medications would you stop? Homegoing. Okay. Yeah. Yeah. Yeah, exactly. Very good. Like you said, he wasn't taking it, and then the lidoderm patches, and then in lieu of hydrochlorothiazide, you're going to give him Lasix. And you already pointed out the Lipitor 20 to 80, and then continue his metformin and albuterol homegoing. Okay. So then what's his disposition plan? So who and when should he follow up with these providers, and then what does he need at the time of discharge? So take a couple minutes again, talk with your groups, and then we'll go over that, okay? Yeah, it's fine. Then put that in there. That, yeah. All right, guys. Who should he follow up with the outpatient? This top corner over here. What do you want him to see? Sure. Well, we already talked about he's going to go home, right? He's functionally doesn't need a sniff, but good that you're thinking about it. So you want him to see his PCP and heart and cardiology. When do you want him to see them? Okay. So for every patient, they need to see their PCP, and if they don't have a primary care doctor, you can send them to the MedCare clinic and the resident clinic, and everyone needs to see their PCP within 1 to 2 weeks or 7 to 10 days. Okay, and then specifically, he should see heart failure. Okay, and in about 2 to 3 weeks, they do have a heart failure discharge clinic that you can send patients to. Okay, so they can adjust their medications. And oh, all right, so the other important thing about when you're discharging someone, so the nodule was new, okay, we'll say that. And he doesn't necessarily need POEM to follow up on that nodule, okay? He can see his primary care doctor, and they can determine if it's, getting worse, then he may need to see them, but maybe start with the repeat CAT scan first. So for any specialty clinic that you want the patient to be seen in, you need to place a referral in the discharge tab, and then you need to talk to the secretary about making these appointments, okay? And he or she cannot make them until that referral's in. You don't want to see their primary care doctor, and if you're anticipating discharge over the weekend, they cannot make specialty appointments over the weekend. So anticipate needing this done on a Friday or sooner, okay? And then in terms of what he needs at discharge, so labs, right? He had an AKI, so follow up with BMP. All right. Imaging, repeat CT chest in 3 to 6 months for the pulmonary nodule. And then supplies. You're sending him home on insulin, right? This is new for him, so syringes. And then if he doesn't have his glucometer, you need to send all those supplies. And then every heart failure patient should weigh themselves daily. So if he doesn't have a scale, we can get him a scale. And then you talked about if he has support at home. So you can also send them with home care, particularly for him, a nurse, to help with meds, daily weights, and new insulin, okay? And then you need to go over all these instructions with the patient, okay, and answer any questions he may have so he understands what he needs to do when he goes home. And then in terms of your discharge summary, right, so the format that we often use here is like at the bottom of the hospital course, you write to do, right? So then the primary care physician should follow up on X, Y, and Z, and then the heart failure team should also follow up on X, Y, and Z, okay? And for the sake of time, we'll just go over that now. So for the primary care doctor, you would tell them to follow up the BMP for the renal function, right? He's HFrEF and wasn't started on an ACE here because of his kidney function. So if his kidney function is improving, he would need an ACE for guideline-directed medical therapy. Titrate the insulin. I heard some of you guys talking about that, right? He has an A1C of 16, and then follow up on the CT chest. For heart failure, they need to adjust all of his medication, not just the Lasix for the guideline-directed medical therapy, and consider a ischemic evaluation for the new onset HFrEF. Okay. That's the end. Do you have any questions or concerns? Anything? No questions? Okay. That's all I have. One more.